Good evening, tribe. Great to see you. I'm excited for those of you who were super excited about this talk with Abigail, our certified nurse midwife. So welcome, Abigail.
Hello, thank you for having me.
Thanks for giving us your time. We got tons of interest in this topic of conversation. So I'm excited to hear from you and learn from you. And I know the tribe is too. So why don't you just introduce yourself?
So my name is Abigail Lannon Eves. I'm a certified nurse midwife and the executive director at Dada Luz Birth and Health Center in Albuquerque, New Mexico. I graduated in 2000 with my bachelor's from the University of New Mexico and graduated in 2002 with my master's, also from the University of New Mexico with a concentration in nurse midwifery. I was the first student who was accepted from the bachelor's program immediately into the master's program. Into the midwife program. They changed that the year that I applied. After I graduated, so with that, I never did labor and delivery. I did postpartum as a nurse extern before I got into midwifery school. And after I got out of midwifery school, I worked on postpartum still for about 6 months. And then I got a labor and delivery job for a year before I was hired on as a nurse midwife. So I've been practicing midwifery since 2003.
So you were on L&D as a nurse and then as a nurse midwife? Is that what I understand?
Yeah, so when I graduated, the nurse midwifery groups here were totally saturated and there were no jobs. So it took me about 18 months.
Oh, that's cool. Probably gave you a nice segue into your career. So what led you or what interested you in a career of midwifery?
For me, it was a calling. I knew from a very young age that I wanted to catch babies. I was always very interested in my mother's birth stories. My brother was born as a double footling breech in New York City, which this is 44 years ago now, when breeches were still delivered vaginally. And then I was born here in Albuquerque, and I just remember her telling me she had a really fast labor, and I was just amazed by it. And I used to give birth to my Cabbage Patch dolls, and I used to breastfeed them. And by the time I was 12, I knew I wanted to deliver babies for sure. I didn't know what a midwife was till I was 14. My sister had a home birth with my niece, and that sealed the deal for me. And over the next few years, I learned the difference between certified nurse midwife and certified professional midwives and decided to go the CNM route.
That's great. That's awesome. So those of you who are joining us live, welcome. Please make sure that you get your questions in. Don't be alarmed if I don't ask your question right away. I will get to it as it flows within our conversation. So go ahead and get your questions in if you have questions. So what did you do prior? You said that you spent some time in L&D. Did you do anything prior to that, a doula or anything like that prior to your midwifery?
Just postpartum as a nurse extern. I started college in '94, and it took me 3 tries to get into nursing school. So, that it's hard to get into nursing school. I had to take classes over. I also had a baby in '96, so that put me a little bit behind. So started in the summer of '99. So between my junior and senior year, I got a job at a local hospital as a nurse extern on the postpartum floor. And the only thing I couldn't do was pass meds. Otherwise, I could do full mom and baby care. And so I did that all through the rest of nursing school and all through midwifery school. And I focused also on lactation and lactation services at night, which were really missing in that hospital. And so I really honed in on my postpartum and newborn skills significantly there, but otherwise that was all my nursing before midwifery school.
Okay, that's great. So you were the first, I think, right, to go straight from nursing school into the midwifery program here in New Mexico.
That's correct.
Would you recommend that path for other nurses? Why or why not?
I think it really depends on the person. I think there are a lot of women, mostly women, I shouldn't just say women, but who are called to midwifery, like really called to it. It's like I can't not be a midwife. It's like I can't not be a woman. I can't not be a daughter. It's part of who I am. It runs through my blood.
Sure.
And so for me, I didn't really want to be a nurse. I wanted to be a nurse midwife. The nursing skills that I got were incredibly important and so valuable. And I'm looking back, I'm so glad that I actually ended up with that year of labor and delivery.
Sure.
And it was hard in some ways, but it taught me so much. So when I did get a job as a midwife, I could just slide right in. I just think it depends on the person. I think some other students who've been accepted straight into the program have had a harder time. I had a little bit of a hard time because in some ways, like I was their star student who was getting accepted for this first person. But then they had such high expectations that I think they also felt like they took a gamble on me. So I got a lot of mixed messages in midwifery school sometimes. But I loved it. I was so passionate about it. It was easy for me to go from nursing into midwifery.
Do you find that that's a common practice still today to accept nurses straight out of nursing school into midwifery, or less common now?
I don't think it's very common. I know here at UNM, there's maybe one every year that they accept. I think most of the time, I find, a lot of women who maybe gone and started a family and have been in nursing for a while, and then they're coming back into midwifery. But definitely some of the younger students. I was 24 when I finished nursing school and 26 when I finished midwifery school. So kind of on the younger end, but almost all of my, I was the second youngest in my class. So we had, midwifery school is usually full of much older women in general than 20-year-olds. So I don't think it's that common. No.
Okay. Interestingly enough, straight out of college, I was accepted into nurse midwifery school. And before I started the program, I talked to my aunt, who's a nurse practitioner, and she was like, "You're crazy. You've never even stepped foot in a labor and delivery unit. Like, you're crazy to go into nurse practitioner school if you don't even know what that's like." And I was like, well, maybe you're right. And so then I got super scared that I was going to hate it, and I dropped out and I never went back.
Yeah.
But I found my passion, so that's okay.
Well, that's good. That's good.
Yeah. So can you talk a little bit about the different levels of midwifery and how you would encourage those that are interested in pursuing a career in midwifery? What angle would you recommend, I guess?
Yeah. So there's basically two different ways that midwives are licensed in our country. So there's certified, three, I should say. There's certified nurse midwives. So we have a bachelor's and a master's in nursing. There are certified midwives, which are midwives who have a bachelor's in something else and then get a master's in midwifery. There's only, as far as I know, a couple of states who have certified midwives, and they're kind of grouped under the CNMs. And then there's what are called certified professional or certified licensed midwives. And those are direct entry midwives. So those are midwives who might not have any medical training at all. They learn through apprentice programs. So they usually do 2 to 4 years of apprenticing with local midwives. They almost exclusively, they do only work out of hospital. They do a lot of home birth setting and some birth center.
Okay.
They have no prescriptive authority. They have to take a licensing, like a certification exam. They are not legal in all 50 states. They are here in New Mexico, and they have been for many years.
Okay.
So for me personally, I wanted to have more authority, and I don't mean that in an authoritative sort of way, but I wanted to be an independent practitioner, and it was important for me to have prescriptive authority. And so in the state of New Mexico, certified nurse midwives and nurse practitioners are completely independent. and we have full prescriptive authority. So any decision that I make, and if it's a bad decision, falls on me and nobody else. And licensed midwives in New Mexico are independent as well. They have a few more regulations, and I think in general, licensed midwives and certified professional midwives, we use those terms interchangeably for direct entry midwives. Unfortunately, they're not very well regarded anywhere in our country. And you'll often hear people call them lay midwives, which is really a misnomer. That is not a correct term. A lay midwife would be somebody who's never had any formal training. And then really, yeah. So licensed midwives, certified professional midwives still take licensing exams and everything, and they do apprentice programs. So I think it just depends what route you want to go. And I think it depends in some ways how hard you want to fight. Nurse midwifery here in New Mexico is really well established, as is licensed midwifery. But they definitely have to just fight harder to be respected. And I think that's a shame. There's also a big kind of us versus them between licensed midwives and certified nurse midwives, which I always find disappointing. I try to look at it as hospital-based midwives and community midwives. And the community midwives are out doing birth center and home birth. And if we can have an integrated model where we can consult with certified nurse midwives in the hospital or physicians, we'll have better birth outcomes. Okay.
And do you find that that is a common practice to collaborate between those two services?
Not so much. No, I don't really have much collaboration with the licensed midwives. I'd like to more, but I think they still, all the licensed midwives that I know of are doing home birth. There are no other birth centers in the state. There's one that they've been trying to get up and running in Espanola, which is run by licensed midwives, but we're the only licensed and accredited birth center in the state. So I had some dealings with them when we were getting licensed, but other than that, I haven't had much interaction with the licensed midwives.
Okay. A viewer asked, were you able to work while you went through the program, and what do you suggest for those with kids?
Yeah, so at UNM, and they discouraged us from working. And I will point out, I was a single mom and a completely single mom. My ex-husband was gone. I did have family that helped me. And I had to keep working. I took out the maximum of loans. I got scholarships, and I still had to keep working to make ends meet. I didn't work full time except in the summers, but just enough to, again, make ends meet, and it was doable. It was for me, yeah.
Good. Hopefully that answers your question, Savannah. So what's the process of training a brand new midwife? What is that like? And maybe in your setting, I don't know if you hire brand new midwives straight out of school or not, but maybe in your setting versus a hospital setting, what is that training like?
So we do hire new grads at the birth center. We've hired 2 that were fresh out of midwifery school. And it's hard. They both oriented for about 6 months. So you can imagine that's hard on the staff, the other midwives, and it's hard on the orientee. And in the birth center setting, we're not doing tons of births. It's not like being in a hospital where you might catch 2 or 3 babies every 12-hour shift and have all sorts of different things going on. These are low-risk women. So they're, 90% of our women who come in who are admitted for labor will birth at the center. So they're usually very straightforward labors. So it just takes a long time to get oriented and to really feel comfortable in that setting. And then, in a hospital setting, you've got lots of nurses, you've got doctors around, anesthesiologists, all sorts of other people. And at the birth center, it's you and your nurse and whoever's training you. You have to be on it. You have to have good skills. And you really have to trust birth. You have to trust birth, and you have to trust that when you really know normal, you will then be able to pick out the abnormal. So, it's hard, but the nice thing about new grads is we can kind of mold them. And it can be hard sometimes transitioning midwives who come from the hospital setting, who, you know, are jaded, you know, and sometimes it's hard because they're used to having so many people and so many services that, you know, we really operate as like our own little family practice.
Sure.
And you just really get good at prioritizing and critical thinking and trying to figure out when do I consult with a physician, or, you know, when do I just consult with my practice partners, or when do I just decide I'm going to make this decision to bring this baby back in 2 days. I don't need to consult about it anymore. It takes time.
Sure. So what's that experience like as a new midwifery grad in a hospital setting?
I just think there's a lot more support there. And, you know, generally I would imagine there's more midwives to train you, and just, you can get so much more in terms of skills probably under your belt in a much faster period of time. Although, you know, probably one birth at a birth center setting or a home birth setting is worth 3 in the hospital, just because we do more labor support in the birth center. You know, at least in our practice, the midwives go in with the clients, and then we call the nurses in when birth is imminent. So it's a paradigm shift from the hospital setting, where the nurses check them, admit them, or say, hey, I've got someone here, and they call us when they're pushing or whatever. So our nurses, you know, they don't check cervixes. Sometimes they put in IVs, but we usually are putting in IVs if we need antibiotics or narcotics. You know, we're initiating nitrous oxide, all of that. So we use a lot of our nursing skills in labor at the birth center. And so I think in a hospital setting, midwives are using their midwifery skills and the nursing skills. You know, I remember when I did get hired as a midwife, I still did some of those nursing things, and I kind of got slapped in the hand for it. They're like, no, you're a midwife now. And I was like, oh, no, I'm a team player. So at the birth center, those skills definitely are, you know, kind of intertwined more.
Yeah, that's great. So another question, Savannah. She asked, as a new grad, do you feel it's more appropriate starting off in a hospital setting or a birthing center?
Repeat the first part of that. It just got a little garbly.
As a new grad, what do you feel is more appropriate, starting off as a hospital setting or a birthing center?
That's a good question, and I'm not sure I know the answer. I wish I had my gals here who are new grads. It's a very steep learning curve at the birth center, and I do think having some other experience, so probably at least some labor and delivery, is really helpful if you're going to take a job as a new grad at a birth center. Just, you know, and again, in a hospital setting, you know, you're going to see a hemorrhage much sooner than you are probably at the birth center, just because of the volume. Or you're going to see some of these kind of odd things, or a baby that needs some resuscitation. That's another thing at the birth center. We do all resuscitation, full neonatal resuscitation. And that's a skill that as nurse midwives in the hospital, you lose, because you have this whole birth team that you call in if you have a bad baby, or if you're expecting a bad baby, you call the NICU team, or you have your code button. We don't have that. So we have to be prepared for that all the time. So it can just be a lot to take in. I think it really, I don't know. That's a hard question. I didn't know about birth centers until I was in midwifery school, and all 3 of our main instructors had worked at a birth center, and I just fell in love with the concept. And we had a birth center in Albuquerque between, I think, 74 and 84, and it closed down in the mid-'80s due to a big malpractice crisis, and they had about 1,000 babies there. And so I just felt like it's time for another birth center. And so it was something I always wanted to do. I didn't know how I was going to do it, but I just decided I was going to do it. But I sure am glad that I had the hospital practice that I had. I caught about 600 babies at the hospital before I opened the birth center. And so I got some really, really good experience, which I think, being the executive director and the lead midwife was really important for me. But I think our new grads both were very passionate about out-of-hospital birth, and, were able to take on the learning curve.
That's great. All right, so a couple more questions. Renee asked, I've always been interested in midwifery. I ended up in mental health. What has made you choose the nursing specialty? She must have missed the first part.
Oh, yes. So Renee, it's been my calling to catch babies pretty much my whole life. And I wanted to be an OBGYN when I was 12. And then when I was 14, I learned what a midwife was. And I knew even when I wanted to be an OB that I wanted to support women. I wanted to be there with them. I wanted to have a strong relationship with them. I, as a very young person, already knew what kind of role I wanted to play. And so when I learned about midwives, I just knew that's what I wanted to do. Did I answer that?
And then Renee also asked, how do you feel about nurses switching into the field such as midwifery? So maybe I'm guessing she has experience in mental health, as she mentioned, switching from mental health into midwifery.
Yeah. I think sometimes our path to the thing that we're most passionate about sometimes, goes like that. And some of us, it's a very, pretty straight line. But I think the most important thing is, if you feel it in your heart, like, I have to be around birth. I have to be with women during this time. I want to see women have better birth outcomes. I want to see our communities get stronger. And actually, I know a fair number of midwives who came to midwifery from kind of a mental health, behavioral health background, interestingly. And they've often had a background working with women in very specific cases, and then came around to the birth part of it a little bit later.
Never underestimate your experience in mental health. I mean, it's really invaluable.
Absolutely. Absolutely.
So you're an entrepreneur. How did that come about? You said you always had a passion for birthing centers once you found out about it. What were your steps in people that are interested in using their nursing skills and also are interested in being an entrepreneur? How would you encourage them?
You have to have a little bit of crazy, I think.
Yeah.
This has been very hard. We've been open for almost 8 years, and we still aren't quite sustainable. Birth centers in our country, there's, I don't know, about 300 or something, don't last very long. I think generally 2 to 4 years. There are some that have been around for 20, 30 years. But there's always 1 or 2 midwives who will work their tail ends off. I think the biggest surprising thing for me after we opened was realizing that nobody was going to work as hard as I would. This is my baby. My clinical director works about as hard as I do, and because it's her baby too. But all your other midwives, all your other staff really want to have balance. And I think most birth center and home birth midwives, the directors, don't have a lot of balance. We'll do anything to see it last. But it started with me. I wrote my master's thesis on a sustainable birth center model in New Mexico. And then my original business partner, Elisa, who we just rehired last year, interestingly, she and I there's actually a how to start a birth center workshop, and that they're offered multiple times a year all over the country. The American Association of Birth Centers puts those on. And we actually have one coming up here in Albuquerque, May 29th and 30th. So that's a great workshop to start. That professional organization is super helpful. They will set up a developing birth center with an established birth center, so you kind of have a sister birth center to talk to. So we did that in 2007, and we spent the next couple years developing. We decided to become a nonprofit, and so it takes a while to get your nonprofit status. We wrote a pretty detailed business plan. We wrote grants. And then I had a second baby, and he was a preemie. He was 8 weeks premature, and kind of the birth center came to a screeching halt. And then Elisa and I went our separate ways, and we had a board of directors, and we kind of rebuilt the board, and realized that if we didn't open, probably within a year or so, we were going to lose any credit that we'd gotten with the public. And because we had a website, and we were raising money, so people knew we were trying to open. And then I found Melanie, my clinical director, and we found a location, and it just kind of all fell together.
That's awesome.
And there's a lot of hard work in there, yeah.
It's a lot of hard work, for sure. Linda asked, what do you do in case of emergency? Is a hospital setting within the birth center, or do your patients have to be shipped elsewhere?
We have to ship them. So we're a freestanding center. We are located in a little village called Los Ranchos de Albuquerque. So it's kind of on the more northern central end of Albuquerque, if you're familiar with Albuquerque. But our closest hospital is by ambulance, probably 15 minutes, but we don't go there. We go to the University Hospital, which is a little bit further. It's about 20 minutes. So in an emergency, the nice thing is we have our nearest paramedic and fire station is less than a mile away. We have another one that's about 2 miles away, and then one more that's just on 2nd Street, like a mile and a half away. So we, in general, get very, very quick response. The one that's just north of or south of us, those are our county firefighters, and they've been there for a while. The nice thing is we know a lot of them, and so when we call and they're our first responders, they generally know an idea of what they're walking into. And so if we really need to go right away, they're prepared to take us. In Albuquerque, generally, if there's an emergency situation, your first responders are your firefighters, and then Albuquerque ambulance will come. They have the contract to transport pretty much everybody, but sometimes we can't wait for Albuquerque ambulance, and we have to go with the paramedic crew, with the firefighters. But overall, we get a really quick response. Albuquerque ambulance will send out their critical care unit to us if they're able to, no matter what we're calling for, which is really great. So yeah, in a true emergency situation, it's scary, and those minutes feel like hours. But we train for them. We drill every single month for emergencies, and we are always ready for emergencies, which is number one, a hemorrhage that you can't stop, and number two, a baby that needs more than just a couple of breaths.
And I know that you work really closely with a provider in the hospital in your area, the hospital that you like to transfer to. How did you foster that relationship, and how do you feel like your camaraderie with them really affects the birthing center as a whole?
So we are really lucky that our lead consulting physician, Dr. Larry Lehman, is incredibly pro-woman, pro-birth, pro-natural birth. So he started out in Zuni, and, in some of those real rural situations, it's almost like having a hospital birth center, because if there's a terrible emergency, they have to ship women as well. His wife is also a midwife here in Albuquerque. So I met him when I did my intrapartum rotation in midwifery school at the university. And everybody knows that Dr. Lehman is very midwife friendly, and his clients love him. And I told him I wanted to open a birth center, and would he, be our backup physician? And he said, yeah, a midwife student asks me every year. And I said, okay, well, I'll do it though. And so, a few years later, when Elisa came back, we met with him, and he was still willing to be our backup physician. And he's just continued to be there. He and the so we transfer into the family practice group at UNM, and a lot of midwives have to transfer into the OB group in a lot of places. And of course, many hospitals don't have family practice that also do OB. So that's a really special thing that we have. A lot of his team can perform C-sections, and Dr. Lehman really operates more like a midwife in many ways, just in how he cares about them. So if we transfer a mama into him and he's available, he will come back for her birth. He will special them, which is just a really wonderful thing. And so, you know, the thing that they're trying to avoid the most, which is going to the hospital, doesn't always have to be so scary. And he helps really take that fear away. And he's also changed labor and delivery. When I worked as a midwife at a different hospital, there was a lot of hostility when we accepted transfers from the home birth setting, and they were always called failed home births. And I always hated that term because it's immediately this very negative thing. And we should not shame women for where they want to birth, and we should not call them failures. And so I was always the midwife in the hospital who wanted to take those clients because I wanted to show them that they could have a beautiful hospital birth, even though it's the last thing they wanted. And I think Dr. Lehman is the same way in accepting transfers from us and other community midwives. And I think it's what we have established over the 8 years as a model, I think, for integrated collaborative community practice for our country. And there's only a few other practices like what we have. It just makes it so much better. Women have such better experiences. Birth outcomes are better. And we're never afraid to call and say, I've got to transfer this woman.
Dr. Lehman birthed my second child, and I love him. Yes. So do you feel that New Mexico is in need of more midwives or nurse practitioners? That's from Alia. Sorry if I've mispronounced your name.
Absolutely. In these rural states like we have, doctors often don't want to practice in some of the more rural locations, can't pay them enough, whatever. And not that we shouldn't get paid less, really, we do, but we shouldn't. But I think there's a lot of really wonderful opportunities. And I think there's so many people who aren't getting the care they need, whether it's prenatal care or any, primary care, specialty care in so many places. And I think I even hate calling us mid-level providers. It's what we're called, but I think there's so many places for us to really lead the way where I think traditional physician care has kind of failed or is failing. And there's no reason that every single community shouldn't have a nurse practitioner and a nurse and a midwife, some sort of midwife to take care of, everybody. Yeah.
All right, great. I've kept you longer than I normally like to keep you. We have more questions, but I don't want to hold you up. Abigail, how do you feel about continuing to answer questions? It's totally your choice.
Yeah, I actually thought we were on till 8, so.
Oh, okay. Well, I won't keep you until 8. I try and keep them 30 minutes, but we're having lots of questions come through, and I know this is your passion. So thank you for being willing to extend our time. So what does a typical day look like? Obviously, in your setting, it's when a mom is ready to birth, but what does that typical scenario look like when you get that phone call that a mom is in labor?
So all of our mamas have to come to pretty detailed classes. We do a lot of discussions with them about when to call in labor. We really like our mamas to do their early labor at home. We recommend that all of our families get doulas, especially our first-time moms. I think doulas they're so important. Really good labor support. Partners are good, but partners have a high level of anxiety. They're worried about, are we going to get there on time? Are we going to have everything? And a doula can come in and just really focus on the mom and then also focus on the partner, which is really nice. So we get the call. Sometimes they call and they just say, I think I'm in early labor, and we counsel them, call us back when you're contracting every 2 to 3 minutes for an hour that are so strong you can't walk or talk through them. Some of them, if they're group beta strep positive, we do give IV antibiotics at the birth center if they're opting to do that. So we really try to support them being at home to kind of get into a groove and get into a good space with their birth partners. And so that when they come to the birth center, if they're in really good active labor, oftentimes it won't slow down. And we see that a lot in the hospital setting. Women get there and there are all these bright lights and there are all these people and all these strangers, and their contractions stop or slow down significantly. And we don't see that as much. And some of that is the environment, and some of it is that they know often who's going to be there.
Okay.
Yeah. And so then we meet them, we triage them over the phone, decide when the time is to meet them at the birth center. Depending on her history, if it's like her fourth baby, I'm going to call my nurse and probably have her there with me. If it's her first baby, I usually will go on my own and evaluate her first, and then call my nurse in when birth is imminent. And we've got one nurse and one midwife for a birth. Sometimes we call in a backup. You get a feeling. We listen to our feelings. Have a baby. Assuming everything is okay, the nurse takes over all the postpartum and newborn care, the immediate care. We have lots of paperwork that we do. The midwife stays in the building for several hours. We do a newborn exam after a couple hours. We really want them to do skin to skin for those first 2 hours, or the golden hour. We have 100% breastfeeding initiation rate. So every single woman who's ever birthed with us has initiated breastfeeding, which is pretty amazing. We can repair them if they need a repair up to a 2nd degree. 3rd and 4th degrees, we'd have to transfer them to the hospital. We can manage hemorrhages. And if everything looks good and mom and baby are doing well, they can go home as early as 4 hours.
That's great. And then what does your follow-up look like?
So for a dyad that births at the birth center, we do a home visit 24 to 36 hours after they birth, as long as they're within 30 minutes of the birth center. If they're not, then they just come back to the birth center for that next visit. If everything looks good, then we see them at a 3-day visit. So mom's milk is coming in. Bilirubin is starting to peak. So we draw bilirubin. We see babies for the first month of life. So we'll draw Billy if we need to. We have full lactation. We've got 3 IBCLCs on staff. So if we need lactation, they're available. If everything looks good there, then they come back for a 2-week visit. That's a mom-baby visit. We do the metabolic screen at the first visit and the 2-week visit. If everything is good there, then we see the baby for a 4-week visit, and that's their final visit. We do a hearing screen, and then we do a 6-week postpartum visit for mom. And if we need more visits in between for bilirubin, depression, mastitis, lactation, we'll work all of those in.
That's great. That sounds like a really great, well-rounded, full family service. I love it.
Thank you.
So we got another question from Savannah. She said, having an 8-week preemie, I'm guessing in a sense, a more medical birth with your second child. How has that impacted your practice and the care you deliver to your lower risk patients?
It's a great question. It was shocking. My first son, I had a long labor, but I had an unmedicated labor. And then the second baby, 12 years later, I had an emergency C-section. He stopped moving and he crashed once we got to the hospital. And it was terrifying. And for a long time, I wondered why me. And, that birth trauma doesn't ever go away. And any woman who's ever had birth trauma will know it doesn't ever go away. But then once we had our first client at the birth center who had, I think, a 32-weeker. She got HELP syndrome, severe HELP, and they delivered that baby via C-section. I realized I had something else to offer and how important that experience actually ended up being. And that has healed my trauma a lot, to be able to go into a NICU and say to a mom, NICUs are really hard. Some nurses are really good about breastfeeding, others are not. You can say, no, you can't do that. You can say yes. You ask a lot of questions. It really helped that I had the experience. Because when I was in the NICU with him, I was a mom. I wasn't a midwife anymore. They didn't even exist in my head. I was just a mom. But there were a lot of things that, because he was in the NICU in the hospital that I worked, that at least I knew the doctors and I knew some of the nurses, and I did have the wherewithal to say, no, I don't want that. Whereas a lot of moms don't know what they can refuse, and not
Sure.
trying to encourage them to be difficult or anything.
Yeah.
But we do a lot of unnecessary stuff in all healthcare. We do.
That you have a voice and that still is your baby, right?
Yep, exactly.
Yeah. Agreed. So the other questions that had been, I feel like, let's just characterize these few. Let's just sum it up with these. What do you feel like a good characteristic to have, or good characteristics to have in maybe not necessarily just midwifery, but birthing in general? What do you feel like nurses and nurse midwives should have in characteristics?
So I think that you should love birth, and you should really respect the birthing process and the birthing woman. A lot of labor and delivery nurses, I think, as in any profession, we can all get kind of dragged down by what we're doing, and it's easier if she stays in bed. It's easier if she gets an epidural, because then all I have to do is take her vitals, and the baby's on the monitor, and that's it. And that's fine if that's what the woman wants, but the woman who wants to have an unmedicated birth and is coming there needs your support. And this is, for any of you who've had a baby, having a baby is like a crucial, critical moment in your life. And it can be absolutely spectacular, even in an emergency setting. It can still be very empowering, or it can be completely devastating. And women who are devastated by their birth process, it's often many times because of the people who've taken care of them, or who have not taken care of them. And, it might have nothing to do with the outcome, but the way they were treated. We are so vulnerable when we're in labor, and, it's always such a bummer when, I hear like, oh, well, the nurse wouldn't let me get up even though the baby was fine on the monitor, or the baby was coming so fast and the nurse held the baby in because the doctor wasn't there yet. Like, you know what? Even if you get written up, catch a baby. Like, give her an experience that she can walk away from that feels empowering and listened to. I think those are really important qualities. Know what's normal, and every single woman you take care of, what does she want? What is her birth plan? If her birth plan is to get an epidural at 2 centimeters, you go, girl, you get that. If her birth plan is, she wants to squat on the floor and play the drums, empower her to do that. That's okay.
Yeah, I like that. April, I see that you've shared a link, and I'm not quite sure what that is. So I'm not going to discuss that. But anyways, thank you so much for all of the input, all the insight. If anybody else has questions specifically for Abigail, just sit them in the comments and we'll get to them as she sees them. But this has been great. I distinctly remember the nurses that were in with me during my labor, and they were wonderful. And so I agree with you. Like, if you're that person that really loves labor, go do that. That's awesome. Yeah.
They will remember, they might not remember your name, but they will remember what you did for them.
Yeah.
And that's
absolutely important. I love that. And I love what you guys do. Okay, Savannah said, absolutely love the support for my birthing women. This is exactly my view, and I'm glad to know I'm not alone.
You're not alone.
Yeah. All right. Thank you so much, Abigail. I really appreciate it. And obviously, everybody is had tons of questions for you, and you've been so gracious to answer those. So I appreciate it, and thank you so much for your time.
Yeah, thank you. Thank you for having me, and hopefully I'll see you again.
Yes, sounds great. Have a good night, tribe.
Thank you. Good night.